Hello.
Yes, sir.
It's already 9:20.
Yeah, just a minute, sir. We're starting, sir. 2 minutes. Just a minute, sir. We're starting, sir.
Hello.
File actually should have
No problem. Hello.
Thank you, sir.
Okay, boss. Chalo. Hello. Hello.
Yes,
Hello.
sir.
Hello. Yeah, please go ahead. Yeah. Hello. Hello.
Hello.
Hello. Hello.
Yes, sir. Yes, sir.
Hello. Let's start.
Atul sir. हेलो
Yeah.
Hello. Yes.
अतुल सर धवल सर ने 5-1 मिनट लागશે
Okay. We can start with part one. No?
हाँ not an issue sir, we can start.
We are already 22 minutes late. By the time we actually start
Unfortunately, we
with
are late,
introduction and all, it will be another 4-5 minutes. So
Yes, sir. We are now starting. We are starting now. Sorry for the delay, sir. We are starting now, sir. Okay. So, here we begin with our debate discussion, sir. So, good evening to all the moderator and panelists. And hereby welcome Dr. Atul Abhyankar, sir, who will moderate today's panel discussion, our debate webinar. We also have with us Dr. Sanjay Bagani, Dr. Dhaval Shah, Dr. Rumin Shah, Dr. Prithviraj Pawar, who are our esteemed panelists for today's panel discussion. To talk in brief about our moderator, Dr. Atul Abhyankar, sir. Dr. Atul Abhyankar, sir, has over 30 years of experience in cardiology practice. More than voice is cracking in between.
hello.
Sir, maybe there is a connectivity issue from sir side.
Yeah, sorry, sir. Yeah, Dr. Atul Abhyankar, sir, has more than 100 publications and abstract to his name. He's also won the 2 Best Paper Awards, as well as he is the editorial consult for CCI, Indian Heart Journal, International Journal of Cardiology, and so on. So this is more about Atul Abhyankar, sir. So with this, we will begin with our debate discussion, which we scheduled for today evening at Surat. So this is the first case which I will be presenting to you all, sir.
I have made some questions to make it shorter. So I will be asking questions, and I believe the panelists have some idea about what questions we are going to talk about.
Sure, sir.
So they can use the slide If you don't mind, can you just introduce all the other speakers? Then I can begin.
Yes, sir. Yes, sir. With for today's debate discussion, we have Dr. Sanjay Bhagane, sir, Dr. Dhaval Shah, sir, Dr. Rumin Shah, sir, and Dr. Prithviraj Pawar, sir. We have for today's debate discussion.
Okay, so we're good to go. Shall I take
Yeah.
over and start?
I'll present the case, sir, if you suggest.
No, we don't want to talk about one case. We
Okay.
want to raise questions and
Sure,
discuss.
sir. Sure, sir.
So the just for benefit of whoever is listening and for benefit of my co-panelists, what we are going to do is I'm going to ask some certain questions. I would request the panelists to give their opinions on those questions. And then if somebody else wants to have a specific comment or anything, then they can have a specific comment, or then at the end of the part one, that is about the NOAC part, we will have some kind of discussion and then we will move on to part two. Now, we were hoping that the number of questions that I have divided into, that we were considering that every panelist gets about 3-4 minutes to answer every question. But now since the Duckworth-Lewis formula is into picture, so probably we will have to cut down that time to somewhere around 2.5 minutes, because we are already 30 minutes late. And I'm sure that even though we will go a little longer than what we planned, but at the same time, we don't want to really become too late. So without wasting any further time, I sort of welcome all my co-panelists. Hello to everybody. And for the first part, it's going to be Dr. Rumin Shah and Dr. Prithviraj Pawar, who will be sort of taking the questions, and they will give their opinion. You can, I think, you can put up the slides, stop sharing them, and if any of the panelists want to share any slides during their answers, they're most welcome to do so. But otherwise, we will just be sort of having a open discussion. And as I said, that the somebody to whom this thing is addressed, he will answer the question, and then subsequently other panelists, if they feel that they want to add something or they have specific comment on that, then they will sort of add to that. So beginning with the first part, Dr. Rumin Shah, are you sort of ready to take the first question? Dr. Rumin?
Please go ahead. Please go ahead.
Yeah, okay. So we are going to talk about the AF and related stroke, and then the role of NOACs, and then specific choices of NOACs that we have in certain situations. My first question to Dr. Rumin is, what are different types or patterns of atrial fibrillation, and do they really differ in terms of the risk of embolic stroke? So what's the risk of embolic stroke, and what different types of atrial fibrillation, do they have different risks, or do they have all the same type of risk?
So atrial fibrillation, as we know, is an epidemic nowadays for various reasons, including longer survival of heart patients and successful treatment of infarcts and hypertension. Anyway, so we do see a lot of kinds of atrial fibrillation, including a lone atrial fibrillation. Sometimes the first diagnosed atrial fibrillation, that is the first presentation of a patient coming to us with atrial fibrillation. This is the first ever diagnosis of atrial fibrillation way. Then you have paroxysmal atrial fibrillation, which comes and goes. It is not a persistent atrial fibrillation. And then you have persistent atrial fibrillation, which is a fibrillation which is seen all throughout. You have a long-standing persistent fibrillation in which there is continuous fibrillation of more than 12 months duration. In persistent fibrillation is one in which it is sustained beyond 7 days, including cardioversion termination. And then you have permanent atrial fibrillation, which is a long-standing atrial fibrillation, and the despite our attempts with chemical, that is pharmacotherapy, and version, the patient remains in atrial fibrillation. So these are various types of atrial fibrillation: a paroxysmal, persistent, long-standing, and permanent atrial fibrillation. Over.
So the question was in the context of these various types. What is the difference in the risk that they pose?
Right. So it is believed that the more the long-standing atrial fibrillation is, more are the chances of patient having embolic stroke. However, a lot of epidemiological studies have proven that even a lone atrial fibrillation or one episode of atrial fibrillation makes a patient vulnerable to stroke. Of course, the longer the duration of atrial fibrillation, the longer are the higher are the chances of complication. But even with this lone fibrillation, there are chances of patient going into embolic stroke. And then there are various other coexisting morbidity and mortality, which could precipitate this. For example, a left atrial size and the other metabolic disorders. Over.
So just to re-emphasize what Dr. Rumin Shah has already said, is that all types of atrial fibrillation, whether they are permanent, persistent, or paroxysmal, carry a risk of embolic stroke. And it would be, it's wrong to assume that paroxysmal atrial fibrillation is a safe kind of atrial fibrillation and that it does not or has a very minimal chance of embolic stroke. So it has, even a paroxysmal AF has, if not more, has a similar chance of an embolic stroke. So my next question is to Dr. Prithviraj Pawar, is what is the comparative risk of a stroke that is due to atrial fibrillation, means embolic stroke due to AF, and any other stroke? So how do these strokes due to AF kind of differ from the strokes not related to AF?
Yes, sir. Good evening. First of all, the question is well noted. And as we all know that, as Rumin sir said, apart from this type of atrial fibrillation, we all know that atrial fibrillation is the most common arrhythmia across globe, be it any age and be it any gender. And irrespective of the occurrence of or the reason of atrial fibrillation, the stroke risk definitely increases with atrial fibrillation, and cumulative incidence of stroke in atrial fibrillation is 6 times more compared to the persons who develop stroke who does not have atrial fibrillation recently or in the past. And not only this, the mortality in patients of stroke who are having atrial fibrillation is more compared to the patients of stroke without having atrial fibrillation. So overall stroke burden, whatever the stroke burden is there, atrial fibrillation increases the occurrence of stroke as well as the mortality of the stroke due to atrial fibrillation. Thank you.
So again, just to give a small conclusion, that cardioembolic strokes have relatively worse outcomes compared to strokes which are due to local cerebrovascular kind of causes of strokes. So this is something very important because these strokes are more prognostically worse as compared to other strokes. The next question, coming back to Dr. Rumin Shah, is that we know that atrial fibrillation has a higher risk of stroke, but just knowing is obviously not of any good. Can we actually, knowing that atrial fibrillation increases stroke, can we do something about it? Can we prevent this, actually these strokes which have higher mortality or poor prognosis?
Knowing fully well that atrial fibrillation predisposes to cardioembolic stroke, the onus is on us to risk stratify such patients at the earliest. With help of so many good calculators available, a CHARTS-VAS score, we can find out the vulnerability of a patient who is likely to develop cardioembolic stroke. And finding out from these parameters, depending on the high risk profile or the score, we should put them on oral anticoagulant therapy as soon as possible. This can prevent the onset of stroke to a large extent in most of the patients of fibrillation who are likely to get stroke. Thank you.
So we saw that the strokes can be prevented, and anticoagulant is the mechanism of preventing stroke. So the age-old anticoagulant that we know of is obviously warfarin. So my next question to Dr. Puar is that does warfarin work in prevention of stroke? And there is always a maybe a misconception or generally a belief that why not aspirin? I mean, you have certain patients, you know, you can just give aspirin for stroke prevention. So is actually warfarin better than placebo or aspirin?
So that this is a very important point, which recently during this COVID pandemic also we have seen many of our colleagues and practitioners. We were just utilizing ecosprin or aspirin just for prevention of coagulopathy or in cases of increased D-dimer. But we all know that aspirin is an antiplatelet agent, and antiplatelet agent cannot replace anticoagulation. So in a stroke prevention, our major goal is to give anticoagulation. So I will definitely and very strongly say over here that aspirin cannot replace or cannot be compared with warfarin or any oral anticoagulation or an injectable anticoagulation for the stroke prevention. It has been proven well in many trials, be it a CAFA trial, be it a RAFT trial, or even if I have to produce some information or a data over here, then I would quote a very landmark old time-tested study, that is stroke prevention in atrial fibrillation, in which a very old and our known warfarin was compared with aspirin and placebo both. And what was the conclusion in that large study? That warfarin, when it was compared with a placebo in prevention of a stroke, it was almost 64% relative risk reduction in warfarin group compared to placebo. And when it was compared with a single antiplatelet, that is aspirin, I mean warfarin and aspirin were compared in stroke prevention. In that also, warfarin has proven its superiority in stroke prevention by doing almost 30% relative risk reduction. And these numbers are very huge. So no doubt we keep placebo aside, but if we talk about aspirin and warfarin only for the stroke prevention, then our concept and our decision is completely clear that anticoagulation is must for the stroke prevention, and that can be given by old age warfarin or a newer anticoagulants.
So basically, as you rightly said, that aspirin and warfarin or any anticoagulant are two different classes of drugs, and they cannot be kind of considered substitute of each other in any way. The interesting part is also that probably anything that is CHA2 to score of 2 or more deserves an anticoagulation. So the only place, if at all, for aspirin is when you have very low risk. That means if you have a CHA2 score of 1, then that is the only place probably aspirin. That means basically you don't want to anticoagulate the patient because the risk is extremely low. So anybody who has got a reasonable risk, then anticoagulation is the kind of only option. I mean, you sort of said about aspirin and said that warfarin, means anticoagulation is definitely superior. So I will come back to Dr. Rumin Shah and ask him a question as to, okay, but that is the time when we used to have only aspirin as an antiplatelet agent. Now we have very powerful antiplatelet agents, and we are using dual antiplatelet agents in many high-risk scenarios. So what do you think that if we use a powerful dual antiplatelet therapy, how would it compare to using anticoagulation? So we spoke that definitely aspirin is far inferior, but what if we were to use DAPT for prevention of stroke?
So the question is, can we put aside, let's say, warfarin or or dabigatran or rivaroxaban and give the patient or continue the patient to be on aspirin and clopidogrel or aspirin and ticagrelor or aspirin and prasugrel. Maybe there are people who believe that you give 150 milligram of aspirin and 150 milligram of clopidogrel, and that is going to be an excellent tool. In fact, when you give double antiplatelet agent, besides the chances of bleeding, there are all other chances of GI upsets also. And studies have proven clearly that double antiplatelet agent, although they are excellent in preventing ischemic event in post-ACS, a post-TENS population, they have no major role or no beneficial effect as far as prevention of embolic stroke is concerned. So clearly, when there is, let's say, atrial fibrillation in a setting of ischemic heart disease, even then it is better to give double antiplatelet agent with an oral anticoagulant. In short, a double antiplatelet agent may not substitute for initiating oral anticoagulant. Thank you.
So just to sort of reiterate again that finally dual or whatever, they are antiplatelets, and whatever powerful antiplatelet effect you may have does not substitute it for anticoagulation. So you can say that, okay, ticagrelor and prasugrel are very powerful antiplatelet agents, but howsoever powerful they may be, they will not be able to act as anticoagulants, and therefore their role remains definitely, the anticoagulants remain to be the choice in atrial fibrillation stroke prevention. Coming back to Dr. Puar, I'll ask you that there are 3 NOACs available in India, and we have a choice amongst NOACs. I know that answering this question in 3 minutes or so is a very, very difficult task, but I would just want you to have a very brief overview about, do you have a choice? That means, do you choose out of these NOACs, or you think that they are interchangeable? So, you know, we know that NOACs are superior to warfarin. That's a kind of established fact. But we have 3 NOACs. So can you just say what is your choice, or do you exercise a choice, or you just do whatever you think?
Okay, this question is very interesting. A few of my friends and a colleague also frequently ask this. Yes, we do have 3 NOACs available in our Indian market, that is dabigatran, rivaroxaban, and apixaban. Endoxaban is not available as of now. It may come in future. Now, any of these molecules have proven superiority with warfarin, that you already said, sir. So if I have to choose among any of these 3 agents, then definitely there should be some points, some benefits versus risk, or negative points compared to a positive points on which I would choose among 3 NOAC available. So all 3 are very good molecules. All 3 are very powerful as far as the anticoagulation is concerned. So any molecule we have to choose, there are 2-3 points on based on which. One is the cost. Of course, in India, I will talk about the cost first. Then second is their superior, their mechanism of action of the beneficial effect over the patients. So there is no any robust or any very significantly different beneficial effects of all 3. All 3 have proven their benefits in RELY, ROCKET-AF, and other landmark trials. So they are good. Another point, which is a side effect pattern or the tolerance of the molecule by the patients. So I think dabigatran is having some increased GI upset as a side effect compared to other 2, which is not there in other 2. But if I keep this GI upset aside, then there are no major side effects apart from a bleeding risk associated with anticoagulation. And whenever we are talking about a comparison of any molecule, then there should be one important factor to talk, that apart from a cost, the cost is of course there. So now these drugs are also coming under a reduced cost, and they are moreover affordable to the people or the patients. So and the most important factor based on which I will choose my choice among these 3, if I have to choose, keeping a cost aside, because there is definitely lower cost for all 3 molecules, but the comparative cost is still differ. One or the other molecule is costlier than the other 2, but the mortality benefit. So all the 3 landmark trial, if you take one each on all 3 landmark trials, then dabigatran has proven cardiovascular mortality in more significant way compared to other two. That is one plus point to choose a dabigatran over rivaroxaban and apixaban. And the second most important point on which I will give my vote to dabigatran compared to other two is a reversibility of the agent. That means the availability of the antidote for any molecule or the medicine. Of course, we are using this as an anticoagulation and we are giving at a higher dosage. So there are, of course, increased bleeding risk. And whenever some patient, on a rare occasion develops a life-threatening bleeding with a hemodynamic compromise, then we really need to reverse the molecule effect or the effect of anticoagulation by particular molecule. So among these three, only dabigatran is the molecule for which the reversal agent is available as of now. Other two are also supposed to get their respective antidote, but as of now, it is not available. So based on these 3 points, mortality benefit, number one, second, comparable as efficacy and benefits compared to other two, and the third, availability of a reversal agent, I will definitely like to choose as a dabigatran, as a NOAC for any patients of mine, if I put a relative GI upset as side effect aside.
Actually, this is something where I would even want the other two panelists who are going to be in the latter part of the discussion. So, I mean, they are not kind of prohibited from making any comments. I would like to get their opinions too. But just in the interest of time and just to complete the theme and then probably come back to the choice of NOAC, I would sort of ask just a couple of quick questions to both of you. Dr. Rumin Shah, can I ask you as to how do you weigh the bleeding risk when you choose a NOAC? Do you differentiate between patients in terms of choice of NOAC between the high bleeding versus low bleeding risk patients? And what do you choose?
So after risk stratifying with Childs-Wass score, depending on the patient's comorbidity, I always resort to Hasbled score. And it is this score which tells me the propensity of a patient who is likely to get a minor or a major bleeding. And depending on that Hasbled score, if that score exceeds 3, I am very cautious in starting NOACs, or I'll make sure that that a drug which has some reversible action or some reversible agent is given. So my gut feeling is going to be on Hasbled score, and then obviously the other comorbidities that patient has. Thank you so much.
I think Dr. Puhar had already sort of touched there on that point, but just to ask that one small question again. How much importance do you give to reversibility in choosing a NOAC?
Sir, actually, if we see the reversibility or the reversible agent for any anticoagulant agent will be required only in 2 occasions. Either it may be a life-threatening bleeding with hemodynamic compromise, which really needs all hemodynamic improvement parameters or the steps as a resuscitation measure. And along with that, if the bleeding is still not controlled, then we have to use reversible agent. That is one. And second, any of patients who are on newer anticoagulation or on anticoagulation and who have to undergo any urgent surgical intervention. During that time, specifically in any neurological surgeries or any life-threatening or any major accidental injuries or multiple surgeries are needed on an urgent basis, during that time, we need to reduce the anticoagulation effect of any molecule which was already on in that particular patient. Of course, whenever we go to choose for reduction of anticoagulation effect, the relative increased in thrombolytic event or thromboembolic event will be explained to the patient. So we have a lot of parameters whenever we face any of these 2 conditions. We do have a replacement with platelets, replacement with plasma and coagulation factors. If we have one more option of dialysis, which we usually use to reduce effect of any poisonous substances or any molecules. So as far as my information and knowledge is concerned, yes, dabigatran do have capacity to get dialyzed by doing hemodialysis, but for complete removal of this molecule almost take 4 to 5 hours according to data. I am not sure about how many hours rivaroxaban and apixaban takes, but that is very obvious that it won't be that fast like what reversible agent may reverse the action of any anticoagulant action. So based on this information, I would definitely be more inclined towards using reversal agent if I have to face any of these two life-threatening condition which needs to reduce or to reverse the anticoagulation effect of any molecule.
So basically, the dabigatran is the only agent which has a specific reversal agent available. There is a reversal agent available for other NOACs called andexanet alpha, but it is not yet available in India. One. Second thing is that it's somewhat non-specific. It requires a continuous infusion, unlike the idarucizumab, where you give just one-time injection. So the ease of reversibility is significantly more in case of dabigatran. So I think one has to consider that somebody who has a higher propensity to bleed, and you are also looking at a good agent to prevent embolic stroke, then you have to consider dabigatran in that context. Just diverging from this discussion, but I just want to let somebody who probably some people, if they are still not aware, that if you use the original molecule of dabigatran, they give you the reversal agent free. But I understand from the one last time's debate that if you use even Debiclot, then they reimburse the cost. They can correct me if there is any change in policy.
Correct, sir. Right, sir.
But that in terms of cost, that is one of the advantage. That is just for information of maybe some people who are still not aware of this fact. Now, I'll just make a couple of comments about the choice of NOAC. That there are independent trials showing benefit of each NOAC over warfarin. And these three are independent trials. They cannot directly be compared with each other. Then therefore, we have something called as propensity matched kind of population to show which is better. And you have various registries, the Danish registry, other registries. So if you look at all these registries, you will get a completely confusing picture. One data will say, okay, rivaroxaban is better than dabigatran in this. Another will say apixaban is better in this data. So you can do the hair splitting as much as you want, but there are some fundamental kind of things that are there. One, all NOACs reduce intracranial hemorrhage compared to warfarin. So in terms of reduction is safety and point of view, all NOACs are good. We know that somebody who is very prone or has a previous GI bleed, rivaroxaban is not a good choice. So probably in somebody who has had a GI bleed, currently across the board, all data, probably apixaban is maybe a better choice in those patients who have already had a GI bleed in the past. The third thing is that in patients with renal dysfunction, probably rivaroxaban has kind of relatively more data. I'm not necessarily saying that it is superior in any way, but probably it has relatively more data. So maybe rivaroxaban in reduced dose may be more useful in patients with CKD. And one more point to add is you also must consider if the lower dose of this NOAC has also been proven to be effective. Because many times we tend to use a lower dose. So we must have the data to sort of confirm that even the lower dose is effective in prevention of embolic stroke. So these are the 4 points in terms of choice of NOAC. Before we close this, I will request Dhaval or Sanjay to, if they have any specific comments to make on this, they can just unmute themselves and speak. If not, then yeah, Dhaval.
Yes, sir. No, I have no specific comment about this.
Sanjay, you want to
hello,
add
sir.
anything? Yeah,
Sir, definitely
Sanjay.
you are right. Particularly in renal dysfunction patients, I would not choose dabigatran as an anticoagulant for AF stroke prevention. I would rather go for apixaban or lately rivaroxaban. That is my point.
Right.
Am I audible?
If any of the, you are very much on. So if any of the panelists would want to add anything, any specific comment, anything that we might have missed in this short coverage of the vaccine app, if anybody would want to add anything, if not, then we will move on to the second part of the discussion. I thank you very much, Dr. Rumin Shah and Dr. Prithviraj Kumar, but I would request to you to please stay on if possible, and in the end, maybe for the other debate, you are free to comment on any of the issues that you think important. So starting this thing, we have Dhaval and we have Sanjay Vaghani. So I'll ask Dhaval to start with. How do you initiate a antiplatelet treatment in an ACS or a STEMI? And many times there is a question that if the patient is already preloaded with clopidogrel, because many times the patient would be seen by somebody like a physician or a general practitioner or say periphery, and they would have already loaded the patient with clopidogrel. So what in non-pre-treated patients and pre-treated patients with clopidogrel, what is your loading sort of regimen?
So the loading regimen for STEMI is well known all over the world. It is standard. We load with dual antiplatelet drugs. One is aspirin. The dose is 325 milligram chewable tablet, but that is probably not available everywhere. Then in that case, we use 300 milligram of enteric coated tablet for loading. And as a second agent, amongst these three, clopidogrel, prasugrel, and ticagrelor, my preference would be on ticagrelor. Of course, the ticagrelor, prasugrel, both are more potent than clopidogrel, but the two issues with the only issue is to prefer ticagrelor over prasugrel is that we cannot load prasugrel before knowing the coronary anatomy, but we can very well load ticagrelor even before knowing coronary anatomy. The reason being, if the patient needs surgery in a shorter time because of bad anatomy, then prasugrel effect would take around 7 days to go off, while the ticagrelor effect will take only 3 days to go off. So preferably, if the anatomy is not known, then I would load with ticagrelor and aspirin. If the patient is, though the efficacy wise, ticagrelor and prasugrel both are superior to clopidogrel. The other thing, if the patient is loaded with clopidogrel, then reloading with a more potent agent is permissible only with ticagrelor and not with prasugrel. That has been proven in a trial. Probably the trial name is Reload, that permits reloading with ticagrelor even in patients who have been pre-treated with clopidogrel.
Right. So let me ask Sanjay, what is your preference of DAPT in post-PCI? But also there are a lot of physicians, or there are a lot of places where probably the PCI is not either offered or the patient doesn't want it or is not possible. So there are obviously medically managed patients of ACS also. So what is your preference for post-PCI DAPT and means for medical management DAPT? How do you treat them, and how long do you continue this DAPT in either case, whether if the patient has the PCI or if the patient is having medical management?
Yes, patients if patient is presented with the ACS, then definitely dual antiplatelet is the therapy of choice. And then post PCI patients, ticagrelor with aspirin, ticagrelor 90 milligram 2 times a day, BD, and aspirin 75 milligram once a day. therapy should be continued till 9 months at least for a post-PCI drug-eluting stents. And if patient is going for a medical management, then also I would prefer ticagrelor as the initial therapy for ACS patient. ACS patient who is going for a medical management rather than putting a stent or rather than a PCI, then I would go for a ticagrelor at least for 3 months. It is my practical scenario. And then dual antiplatelet for 9 months. And after that, according to the clinical criteria and clinical situation, I would prefer either single antiplatelet or dual antiplatelet later on after 9 months. But 9 months is a compulsory for dual antiplatelets after ACS, any ACS patient, whether he is going for a PCI or whether he is for a medical management.
9 months or 1 year? What would be?
Yeah, 1 year. But according to the guidelines, 9 months is also preferable, but 1 year is a practical experience.
Right. So, if medically managed patients, do you have any concerns in treating medically managed patients for 9 to 12 months with ticagrelor 90 milligram twice a day? Or do you think that's as safe as doing it post-PCI?
I guess ticagrelor 9 months is as safe as post-PCI also in a medically managed patient also, because dual antiplatelet anyway we are going to give this kind of patients. As we see, the efficacy is more compared to the clopidogrel in patients with ACS and coronary artery disease patients compared to the clopidogrel. But if bleeding risk is not very high, then I would go for 9 months ticagrelor also.
So Dhaval, let me come back to you. So in what situations would you consider early discontinuation of DAPT? And we know that it is becoming more and more confusing as to when you say, okay, discontinue DAPT, but then what do you do in terms of single antiplatelet, which single antiplatelet, what are the various recent data about them? So in which scenarios would you consider discontinuing? I mean, would you consider discontinuing DAPT at all at 1 month, 3 months? And if then that situation, what would you choose for a single antiplatelet?
Okay, so discontinuing dual antiplatelet therapy prematurely, that is before 1 year, is I mean only if it is medically indicated because of some bleeding issues. So there are 3-4 situations where you would like to discontinue before 1 year. Otherwise, for all ACS patients, whether medical or invasive management, you would like to continue for 1 whole year. The one common situation is patient needing any non-cardiac surgery. That is the commonest indication, the knee replacement surgery, cataract surgery. These are the 2 dental procedure. These are 3 common things which people ask in OPD. I usually tell them to preferably avoid till 1 year if it is not very emergent. But many times there's a mature cataract, or many times patients having very recurrent toothache, and if patient is going to have that surgery for sure. Then in that case, for ACS patients, I would discontinue DAPT after 6 months. So if they ask me at 4 months, I would tell them
let me interrupt you for 1 second.
Okay.
What if they don't have any event?
What
is
if
no
they
event?
No?
If there are no event, that means there is no surgery, nothing bleeding episode. Would you in some patients still consider?
In the other point is, if the patient is also candidate for anticoagulation, then in that case, I would like to minimize the duration of triple anti-thrombotic agents to as low as possible. Certainly, I mean, probably 1.5 months would be my choice. I would make 3 drug to 2 drug after 1.5 months if the patient is also a candidate for anticoagulation, maybe because of atrial fibrillation or having a history of thromboembolism, or maybe mechanical heart valve or something like that. But if there is no bleeding issue and no surgery, then I would never stop antiplatelet before 1 year. I mean, dual antiplatelet before 1 year. I won't make single. I won't make single agent before 1 year. Aspirin.
Yeah, I kind of slightly disagree that now I think we have so many trials to show that in patients with high bleeding risk, that means they never bled, but they have high bleeding risk. Patients with CKD, patients who are very underweight, patients who are very old, very frail. These are the patients, I mean, there are clearly now we have high bleeding risk criteria. And if you have very high bleeding risk, there are already trials showing that those patients can safely be treated with single antiplatelet agents after 1 or 3 months, depending on which trial you are talking of. But yeah, you can discontinue patients. So you don't have to necessarily wait for a bleed to happen or patient to need surgery. You can discontinue. And there is also another point in that whether this should be considered true only in the context of certain stents where this kind of discontinuation of DAPT has been established by trials. So that remains a separate point. But coming back to our question, if you decide for high bleeding risk or for any minor bleed or whatever, which single antiplatelet would you continue?
I would continue with aspirin.
Right. Sanjay, would you agree, disagree? You have any other choices?
No, I'm agree with Dhaval. I would continue aspirin as a single antiplatelet.
What about the TICO and Twilight data?
Twilight data says that beyond 3 months, you can continue with single ticagrelor rather than ticagrelor plus aspirin. But then if the issue is a bleeding risk, then probably the aspirin would be safer than ticagrelor as far as bleeding is concerned.
Why not clopidogrel?
Then if for single antiplatelet, aspirin is a time-tested molecule. So everywhere it is mentioned that clopidogrel monotherapy only if patient is aspirin intolerant in terms of GI intolerance. If you have to choose one from aspirin and clopidogrel, then aspirin is always preferred. The only issue being GI intolerance. Then only would prefer clopidogrel.
And the resistance, yeah.
So again, I somewhat differ in that, yes, now there is a lot of sort of change in the view that if you're going to use a single antiplatelet agent, 2 choices. When there is a clear-cut bleed, then probably you can't continue with ticagrelor as a single antiplatelet agent. Prasugrel nobody advocates as a single antiplatelet agent. So the question is between aspirin, ticagrelor, or clopidogrel. Now, if you're choosing a milder antiplatelet agent, then it comes down to aspirin or clopidogrel. And I think there is now a lot of change in the strategy that if you're using single antiplatelet, probably clopidogrel may be a better choice in that scenario because a lot of issues with clopidogrel are lesser with aspirin. But as I said, that this is not like completely established and there is not a definitive single guideline. That means no guideline says that only this. The guidelines gives you a choice that you can choose from any of these agents. So yes, as Dhaval said, what he said is kind of not something which is wrong, but yes, there are different viewpoints, and because of these different viewpoints, the guidelines kind of allow you to choose in these situations from your choices. Coming back to Sanjay, if the patient has finished 12 months of DAPT and he never bled during these 12 months, that means he had an event-free 12 months period. Yeah. So if Sanjay, if you finish 12 months of DAPT, the patient didn't bleed during those 12 months, now what would be your choice? Would you consider the DAPT continuation further in all or some patients, or would you give necessarily only single antiplatelet? And
yeah, one study has came recently, not recently, 3, 4, 5 years back, that 30 months DAPT is more safer in case of MACE rate and stent thrombosis, very late stent thrombosis compared to the 1 year dual antiplatelet therapy. So according to that data, I would like to prefer dual antiplatelet beyond 1 year in certain patients like diabetic patient, multivessel disease, multi-stents therapy, small vessel disease, long stents, And those who have a high recurrent rate of ACS type of high risk patients, those kind of patients I would like to prefer to continue 30 months DAPT therapy compared to 1 year.
So, would you want to add anything?
No, I think continuation beyond 1 year is hardly helpful, because the incidence of stent thrombosis or very late stent thrombosis is extremely rare after 1 year. So I have never, except in those who are, when I have stented a left main or left main bifurcation or ostial LAD, there I continue dual antiplatelet therapy for 2 years. Rest I always stop beyond 1 year. And I have never continued antiplatelet therapy, dual antiplatelet therapy beyond 2 years in any subset of cases. That is my personal preference.
Right. So what about the Pegasus data? Next question to you, that based on the Pegasus and certain other trials, do you consider in at least in some patients that you should continue the DAPT, and if that's so, what DAPT?
Yes, so Pegasus data, of course, the ischemic complications are lesser, the MACE rate is low, but at the same time that comes at a cost of increased bleeding. So protection in ischemic events by using antiplatelets for a longer duration comes at a cost of increased bleeding. So it is never my personal preference. And if at all I have to use a dual antiplatelet therapy beyond 1 year, I would always use aspirin with clopidogrel. I would never use aspirin with prasugrel or ticagrelor beyond 1 year.
Just to highlight the Pegasus data, the Pegasus actually showed us that in certain patients, means mainly diabetic, high-risk
patients,
multivessel diabetics. These are the patients where if you continue 60 milligrams of ticagrelor, which does not increase the bleeding risk, 90 milligram does, but 60 milligrams of ticagrelor up to 3 years, then probably you give an additional benefit in terms of net outcomes, not just ischemic outcomes, net outcomes. Now, having said that, there are certain sort of ways to choose the patients. So you have to look at the ischemic risk vis-a-vis bleeding risk. So if you have high ischemic risk, and the important part of where the benefit of this delayed DAPT came from is something interesting. And in that context, the data from Cleveland and the analysis of Pegasus shows us that we always think of stent. And so we say, okay, my stent doesn't need therapy for more than 12 months. So I don't need DAPT after 12 months. But stent is not patient's disease. Stent is the therapy. So the patient's disease in some situation needs dual antiplatelet, because the reason there was a superiority of ticagrelor 60 milligram was not because of prevention of stent thrombosis, but because of prevention in areas which were not treated. So that means they were actually preventing new events and not stent thrombosis. So majority benefit came from preventing events in other culprit lesions or other vessels or other lesions rather than the stent related. So that's one of the important aspects to remember, that interventional cardiologists, we always think that, okay, my stent has become safe now. So it's not just a safe stent, you have to make sure that it's a safe patient, because stent is only a one lesion that we have treated, and we have to consider that the patient may have other vulnerable plaques. You have to look at patient's overall disease. So patients with multivessel disease, although treated with 1 or 2 stents, but we know he is multivessel disease. Patient is diabetic, patient has diffuse disease. And these are the patients where continuing beyond 1 year definitely would have a benefit, and that is what has been documented in Pegasus trial and some other data also. So I will come back to Sanjay. And nowadays we are having this new terminology. We used to call something as a stable CAD. Now we say, no, that's a misnomer. There's nothing called stable CAD. And we have replaced it with a new term called chronic coronary syndrome. So what do you think is the importance of this change in our terminology? It's a terminology, or it's the approach which has changed?
Actually, it's always a chronic coronary syndrome, it's never been a stable coronary artery disease because it's a progressive disease, and we can modify the course by lifestyle modification, pharmacotherapy, and coronary revascularization. It's a progressive disease. Because of that progressive nature, we had replaced the term stable coronary artery disease because it's a chronic progressive disease. So we can alter or modify the course rather than we can stabilize the course. So that's why we replaced the terminology. And it consists of this ACS event also, and myocardial ischemia, persistent myocardial ischemia. Even it consists of the heart failure because of the coronary artery disease.
So basically, the term stable CAD kind of indicates that you don't need to do anything. So that means patient is stable, patient is asymptomatic. So you call that asymptomatic CAD is assumed to be a stable CAD. But we know that all these so-called stable CADs or patients who are asymptomatic, 3 years, 4 years down the line, would come back to you with another MI or another ACS.
Yeah.
So that's why this stable CAD suddenly one day turns into an unstable CAD. And that's why this terminology, because this stable CAD gives a false sense of protection, that we think that, okay, I don't need to add anything to the treatment. This is not necessarily in the context of doing another angioplasty, because if the patient doesn't have another critical lesion, we won't offer an angioplasty or bypass surgery. But in terms of lot of new advances in medical management, we know that we still need to be aggressive even if patient is asymptomatic. So an asymptomatic patient does not mean that there is no future risk. And that's why we have changed the terminology from stable CAD to chronic coronary syndrome. So coming back to Dhaval, we have recently had this THEMIS trial, and very frankly, even I don't know whether to call that positive or not, negative or not so positive. So Dhaval, what's your take, or what do you think you knew more from THEMIS trial, and has it changed your practice? What's your take on the THEMIS trial?
So yeah, it has tested ticagrelor in addition to low dose aspirin in patients of stable CAD, but now we call it chronic coronary syndrome. So stable in terms that their clinical course is stable, that over a period of time they get a predictable angina, that after walking such a distance, patient will get angina. Walking lesser than that and patient continues to remain in that state for maybe 1 year or 2 years, then you can label that patient as a stable coronary artery disease, or you can say stable coronary syndrome. So in that case, they have added ticagrelor to aspirin to prevent future cardiac ischemic events. So of course, the ischemic events were statistically significantly lesser in those who have taken dual therapy instead of aspirin alone. But there also the difference was very lesser. The magnitude was very less. There was 7% incidence in the ticagrelor plus aspirin group, and there was 8.5% in the aspirin group. At the same time, the bleeding risk was 2.5% in dual group versus 1% in aspirin only group. So to prevent a small magnitude of ischemic events, increasing the bleeding risk to such an extent is not acceptable, and I would personally not prefer to use dual antiplatelet therapy for stable coronary artery disease patients. So that is my take.
I think Dhaval, right. So I think Dhaval, what you mentioned, I absolutely perfectly right, that actually these so-called stable CADs include a wide spectrum of patients, and therefore, first of all, they were not necessarily same kind of patients in terms of inclusion criteria. The most disappointing fact was that it did not reduce cardiovascular or all-cause mortality. So in terms of hard endpoint like mortality, there was no significant benefit. It reduced ischemic events at the cost of increasing bleeding events, as you rightly mentioned. So my personal take on this is that THEMIS trial didn't tell us anything. I mean, it kind of gave us a confusing message whether we should continue ticagrelor for a longer. But lower dose of ticagrelor, Pegasus showed that post-MI, Pegasus were post-MI patients, right? They were not general angioplasty, stable CAD kind of patients. They were all post-MI patients. So at least in post-MI, after 1 year, post-MI patients, we know that famous graph that MI diabetes both increase risk by 4 times. So that post-MI patients who is relatively high risk, after 1 year, probably Pegasus shows that maybe 60 milligram twice a day probably may be superior to using a single antiplatelet. Lastly, just coming to Sanjay about, we have 2 agents now, right? The 2 powerful agents, ticagrelor and prasugrel. What do you choose and why?
I would like to choose ticagrelor over the prasugrel because the efficacy is the same as we studied, and compared to the clopidogrel, definitely both are superior. But if we comparison between the prasugrel and ticagrelor, I would like to choose ticagrelor because the bleeding risk is little bit more with prasugrel. And second thing is ticagrelor has many studies to prove that it is has superior efficacy in terms of myocardial infarction or any ACS patient or those who are going for a PCI. Third thing is minor bleeding. Day-to-day practice, we can see the minor bleeding risk is a little bit higher with the prasugrel, like gum bleeding or petechia bruise. And some patients have per rectal bleeding and all. That kind of things are more with prasugrel. Third thing is weight is a limitation for prasugrel. Undernourished patients, we can't give prasugrel. Fourth is age, more than 70 age is another limitations for prasugrel. So these kind of patients have major bleeding risk also very high. So on this point, I would like to choose ticagrelor or prasugrel. And second, only one point is there. If severe hepatic impairment patients is there and associated with coronary artery or ACS patient is there, then the ticagrelor has limitations because severe hepatic impairment, we can't give ticagrelor. In that case, prasugrel also has a very high risk for bleeding. So in that case, we have to choose another antiplatelet. Otherwise, in any conditions, ticagrelor is superior. I would like not say superior in efficacy terms, but the safety margin and in terms of prevention of mass events, ticagrelor is superior.
I mean, I totally agree that prasugrel is very powerful, but it has too many no-nos in its list. So not more than 75 years, previous stroke, no, frail patient, no, previously preloaded with clopidogrel, no, medical management patient, no, thrombolytic therapy query. So there are a lot of categories where prasugrel is either no or a question mark. And that's why probably everyone, and I think all of you, my colleagues would agree that our experience shows that bleeding incidences with ticagrelor are lesser as compared to prasugrel, and that's probably we shared this in one of our meetings. Sanjay, I think you were there. We had discussion on this that in everybody's experience, prasugrel causes more bleeding as compared to ticagrelor.
Yeah, definitely. Yeah.
So I think that was kind of the certain things that we wanted to highlight and cover. My previous 2 panelists, if any of them want to comment anything on this, or any of the panelists want to comment on or highlight any new issue or something we missed, which is important, please feel free to unmute and say.
So there are some questions from the attendees.
Yeah.
If you permit, can I ask or?
Yeah. I can't see anything in chat box, but if you can.
Yeah, separate link I'm having actually for the attendees. So there I can see some questions. So if you allow, can I ask the question, sir?
Yeah, please.
Yeah, the question is basically, as per the guidelines, it is recommended to use Hasbulat score before prescribing Novak. But what about my older patients of AF who are having low BMI? There is no mention of BMI in the Hasbulat. So what should I do?
Yeah. Dr. Puar, you want to take that question?
I think guidelines and on the drug literatures also do not mention specifically about BMI. But yes, if BMI is low, then we have already discussed about one point during our discussion on NOAC, that NOAC have advantage of using on a lower dose also. For example, if dabigatran is chosen as a newer anticoagulant for any stroke prevention, and that patient is having lower body mass index, then we do have a lower dose available, 110 milligram instead of 150 milligram. And even someone is underweight, for example, then we do have a 75 milligram provision too. So in that, we can always have a lower dose or the half dose NOAC anticoagulant as anticoagulation. Similarly, for rivaroxaban also, we do have even a 2.5 milligram dose strength available, whereas the full dose or the recommended dose for anticoagulation is 20 milligram a day. So those patients who are having low BMI, then lower dose of rivaroxaban or dabigatran can be used.
Thanks, sir. There is one more last question, sir. Just allow me to ask. My dabigatran patient is about to go PCI in coming duration. So he will be on DAPT if doctor is prescribed. So after the DAPT plus NOAC, which antiplatelet should be withdrawn?
Dhaval, you want to address that question?
Yeah, so as I already mentioned in my talk also that I would like to keep the duration of triple antithrombotic to as low as possible, and maybe after 6 weeks or so I would withdraw aspirin. I would continue with clopidogrel and NOAC in a therapeutic dose rather than subtherapeutic dose of NOAC. So always, if the patient is a candidate for NOAC or any anticoagulation, then use anticoagulation in the therapeutic dose and make antiplatelet single. And in that case, I'll continue with clopidogrel.
Just to add that we don't actually have a specific trial related to dabigatran on this issue. We have trial related to rivaroxaban, where there is a combination of antiplatelet and rivaroxaban. I'm not aware that there is any specific data with dabigatran. So we don't have a specific answer. If patient is already on taking dabigatran and now patient undergoes PCI, then whether single or dual antiplatelet with dabigatran, I think it's not proven either way by data. So what we know is more about rivaroxaban combined with antiplatelet.
So doctor is saying that there is a redual PCI trial which is talking about dabigatran and DAPT.
Yeah.
So he wants to just verify that. Is it so? Can you guide?
Yeah, I don't remember the details of redual PCI, but I think if any of the other panelists remember offhand any of the data of redual PCI, I can't offhand remember redual PCI data. Yeah, anybody can recollect the precise this thing? Sanjay, Dhaval?
So let me recollect.
I think
in the meantime,
redual PCI did not involve utilization of aspirin. It was actually with clopidogrel. It was with dabigatran and clopidogrel, and it was tried with dabigatran and warfarin and clopidogrel. So in all the groups, clopidogrel was already there. So it has not given any additional data as far as the antiplatelet is concerned. So basically the trial was comparing a low dose dabigatran 110 milligram versus 150 milligram dabigatran, and the third arm it was warfarin. So our main emphasis was in triple drug to dual drug combination for any post PCI patient. I think redual trial does not give any additional information for our concern.
Thank you.
Yeah. I think you're absolutely right that the question that has been raised is not kind of answered by the redual PCI trial at all.
Yes, we can always have a debate that if you want to choose single antiplatelet along with anticoagulation, then take a then clopidogrel versus aspirin, what to be chosen? We don't have sure shot data or a guideline. If someone asks me, I will put aspirin as a plus marks compared to clopidogrel, and the point of fight would be clopidogrel does have about 44% resistance, which aspirin do not have. So if I have to choose one antiplatelet among two, then I will choose aspirin. But this point always been into debate, and we can have a CME of 2 days full for this point.
Yeah, as I said, with DLPC, I compared more of 2 doses of dabigatran and warfarin rather than a single or dual antiplatelet therapy. And there's also, I think there were some issues about great diversity in terms of US and non-US patients. So elderly patients were not included in other countries and stuff like that. So I think we don't have any clear-cut answer on that that you asked.
Abhyankar sir, I would like to ask you about, what would you prefer, aspirin or clopidogrel with dabigatran or any NOAC in case of PCI patient?
I think the data that is available is with rivaroxaban. I would rather prefer to go with rivaroxaban because that's shown by the data, right? So, but now should we then switch from dabigatran if patient is already on dabigatran and change to rivaroxaban? I don't have a clear answer to that. But probably I would reduce the dose of dabigatran. Now that we have 75 milligram, probably just logically thinking, I mean, whatever the redual PCI showed us, not exactly correct answer, but I will go with aspirin, clopidogrel, and 75 milligrams of dabigatran. I think that is what I will do.
No, but triple therapy for how long? For PCI patient, suppose patient has AF when underwent PCI, then for let's say double said 6 weeks, we continue for triple therapy, and then we have to choose patient has AF.
I would continue for 3 months, except for patients with very high bleeding risk.
Yeah. Okay. After 3 months, we have to replace. Reduce the anticoagulant therapy. One antiplatelet, one anticoagulant.
Yes.
So
then I would use 110. Then I would probably step up it to 110 milligram from 75 milligram once I reduce one antiplatelet.
No, but and what about antiplatelet? Either clopidogrel or aspirin?
I would choose clopidogrel. Although you can say that a lot of trials used a combination with aspirin, but probably I would prefer clopidogrel.
Okay.
And never use prasugrel or ticagrelor with any anticoagulation. That is also
absolutely.
Prasugrel has no place in triple therapy.
And even ticagrelor has no place in triple therapy.
Yeah.
Are there any more questions?
No more, sir. Questions, sir. So, if you allow, can we come to the closing remarks, sir?
Yes.
Yeah. So, thank you, doctor. We take this opportunity to thank Dr. Atul Abhyankar, sir, for moderating this debate and ensuring the audience are enriched with the clinical experience. We also thank Dr. Sanjay Vagani, Dr. Rumin Shah, Dr. Dhaval Shah, Dr. Prithviraj Singh Pawar for sharing their clinical experiences. We also thank all doctors who joined us for today's antithrombotic debate. And we at Alchem Laboratories will continue to serve doctors and patients by making our products available, that is Tisart, Ticavik, and Dabiplot. So thank you, doctor, once again, and good night for your discussion about today's webinar, sir. Thank you once again, sir. Take care, sir.
Thank you.
Thank you.
Good night, sir.
Thank you.
Bye,
Good
sir.
night. Thank you. Good night.